next point. So child will come with vomiting. So how are we going to differentiate that it is due to gastroesophageal reflux or it is due to a mechanical obstruction in the distal part of the stomach? For that, as we saw earlier, gastroesophageal reflux will come immediately post meal. It will be curdled milk. But if it is an obstruction, for example, a duodenal web or a pre-pyloric web which is presenting with vomiting, there will be history of an epigastric lump, there will be history of stale food vomiting. So these are the points which will point towards a mechanical cause distal to in the distal part of the stomach or in the proximal part of the duodenum. Then finally, we have to take clues from the history regarding what are the associated symptoms. For example, if the dysphagia is prolonged or the narrowing is critical, there will be associated weight loss. If there are repeated episodes of pneumonia, you have to think that this is a tight stricture. Then if there is associated symptom of heartburn and epigastric pain, then you have to think of gastroesophageal reflux disease. And if there's a child who is immunocompromised, there's a history of fever, rash, you have to think of CMV esophagitis. In a child who is exposed to prolonged antibiotics, you have to think of candida infection, so on and so forth. Now we'll take history for etiology. So as all of us are aware, corrosive ingestion is a common cause of esophageal stricture. So we have to take history for the same. In smaller babies, there might be history of accidental button battery ingestion in the past, which can give rise to stricture. There's history of surgery that we have to take for tracheoesophageal fistula repair. We have to take history for GERD. There are certain congenital conditions which might be associated with the lesions in the esophagus which will give rise to stricture. These are, for example, epidermolysis bullosa and pemphigus. Radiation exposure, prolonged radiation exposure may cause esophagitis and later on lead to esophageal strictures. And this is some syndromes are also associated with it. For example, Algro syndrome, AAA syndrome, that consists of alachremia, adrenal insufficiency and achalasia. So we have to ask whether the baby has tears or not, or whether he goes into shock or he goes into crisis during any illness. So we have to ask history pertaining to each case. And sometimes one of the rare causes of dysphagia due to motility issues is scleroderma, that is usually not seen in children, more seen in adults. Now summarizing, so as we learned, we ask about history, onset, duration and progression of dysphagia. Then the character of dysphagia, whether it is to solids or liquids. If dysphagia to solids is more than liquid, think of mechanical cause. If dysphagia to solids as well as liquids and sometimes coming with dysphagia to liquids first will point towards a motility issue. Then we subcharacterize into whether it is an intermittent or a progressive dysphagia. So if it's a progressive dysphagia in children, we are not thinking about malignancies, we are thinking about a esophageal stricture which is worsening with time due to fibrosis. And intermittent dysphagia can be due to rings and certain types of diseases, for example, eosinophilic esophagitis causing stricture. And if it is a motility issue, a progressive motility issue seen in children, the most common condition will be achalasia cardia. Intermittent issues with motility disorders are also seen in adults, not so common in children. Now we are going to discuss about esophageal strictures in detail. So coming to the etiology in children, the two most common etiologies of esophageal strictures are post-staph repair anastomotic stricture and post-corrosive esophageal stricture. The prevalence ranges from about 13% up to 60% in certain studies. These are most of the Indian studies have shown percentage of around 40% of both anastomotic stricture as well as corrosive stricture. Other etiologies like peptic stricture and congenital esophageal strictures are lower down, and there are some rare causes of esophageal stricture, for example, post-sclerotherapy injection, formation of esophageal stricture. So when do we suspect an esophageal strictures? Till now, what we have learned, there will be history suggestive of mechanical obstruction, there will be corroborating background history for the etiology, there may be associated systemic conditions, and then finally, examination we do to look for the chronicity of the illness in the form of weight loss and associated symptom, for example, recurrent episodes of aspiration pneumonia. Now, how will we confirm? We will confirm with a contrast study and finally an upper GI endoscopy. Here again, I have tabulated the acquired causes of esophageal stricture, which is the most common cause. Congenital causes of esophageal strictures are not so common, and again, these two causes predominate. In the developing countries, we have corrosive ingestion. In the developed countries, esophageal atresia with TEF repair is the most common cause. Now, we'll discuss about each etiology in detail. So, first coming to corrosive esophageal stricture. So, in what age group do we see corrosive esophageal stricture? Obviously, in the toddlers and the younger age group accidentally taken corrosive. So, prevalence it varies from country to country. Up to 60% of cases of all esophageal strictures, there are case series which are due to corrosive esophageal strictures. How will we confirm the diagnosis? First by history of ingestion, then by examination, there may be associated hematemesis, oral ulcer, drooling. All this may be seen during the acute presentation of corrosive ingestion. And finally, we do a contrast study after 4 weeks of acute corrosive ingestion to confirm the diagnosis. What is the treatment? Treatment is endoscopic dilatation. If it fails, then surgery is required in few cases. Now, there are some questions, common questions which are seen in case of corrosive esophageal stricture that I would like to discuss. So, we want to know which is more dangerous, acid or alkali. The answer is both are equally dangerous. Acid causes coagulative necrosis and alkali causes liquefactive necrosis. So, both of them equally predisposed to stricture. Next, can we predict that an acute corrosive ingestion will give rise to a stricture? Yes, the answer is yes, we can predict. How do we predict? When the child comes with an acute episode of corrosive ingestion, and if we get the window to do an upper GI endoscopy, we see what is the grade of injury. Based on the grade of injury of esophagus due to the corrosive, we have to grade in a certain classification system, which is called as the Zargar classification system. As per the classification system, there are various classes. We can predict what is the probability of formation of a stricture. So, when do we do endoscopy in a case of acute esophageal injury, like acute corrosive ingestion? Do we do endoscopy at all? So, the answer to this question is, all the guidelines they recommend to do endoscopy carefully and only in the first 24 hours of corrosive ingestion and not later, because the later we do, the more is the chance of injury. So, if the child comes with acute corrosive injury, we would prefer an upper GI endoscopy as per the Aspergen guideline within 24 hours. And when do we dilatation? Usually after 3 to 4 weeks of acute corrosive ingestion, we will do a barium study, then see the stricture and then plan an upper GI endoscopy and dilatation. These are some of the pictures. As you can see, the arrow shows this is the linear and this is the circumferential ulcer. So, this type of esophageal injury is a high grade esophageal injury. This endoscopy was done in acute corrosive ingestion and this injury shows Zargar grade 2B. Now, moving on to the next etiology, that is post-tracheoesophageal fistula repair anastomotic stricture. So, what age group do we expect? Obviously, in the infancy, depending on the difficulty with the surgery, they might come as early as 4 weeks post surgery or later on they will present in infancy. Around 20 to 40% of all pediatric stricture are due to the anastomotic stricture. And the diagnosis, again, after 1 month of surgery, if the child is symptomatic, we can do the barium study earlier also. Treatment is endoscopy in most of the cases. If not, then might require a redo surgery. So, when do we suspect post-tracheoesophageal fistula repair anastomotic stricture? This is purely based on the clinical symptoms. If the child starts to have vomiting post-surgery, then you suspect and you do a barium study. It is not mandatory to do contrastory after a surgery in each baby. Can a post-tracheoesophageal repair anastomotic stricture be dilated? Yes, it can be dilated, and the safe time period to do an endoscopic dilatation is again 3 to 4 weeks after the surgery. Now coming on to the next etiology, that is peptic stricture. So peptic strictures are due to the acid exposure to the lower part of esophagus. This is due to the gastroesophageal reflux disease. So what is the age group that we see? It is most commonly seen in the second decade. There will be associated clinical symptoms of heartburn, chest pain, as seen in GERD. The most common location of peptic stricture is the lower end of esophagus. Diagnosis is by endoscopy, which will show features of erosive esophagitis. Treatment is again by medical as well as endoscopic dilatation if there is a stricture. And rarely those who require prolonged PPI, we will need to do a pH metry test, and if the acid reflux index is high, they might require fundoplication. Now coming to the smaller subset of etiology, that is the congenital esophageal stricture. So congenital esophageal stenosis are divided into 3 types based on their histopathology. What are the 3 types? First one is an ectopic tracheobronchial remnant. As the name suggests, there is a tracheobronchial remnant in the lower part of the esophagus, which is giving rise to this picture. This happens in the lower 1/3 of esophagus alone, and for this we have to do surgery. This is not possible to dilate by endoscopy alone. On the other hand, the other 2 types are the fibromuscular stenosis and a membranous diaphragm. Fibromuscular stenosis usually is seen in the middle part of esophagus, and membranous diaphragm is seen in the upper and middle part of esophagus. This membranous diaphragm consists of only the mucosa and submucosa. So it is very much amenable to endoscopy. So what is the age of presentation? That is seen in infancy, around 4 to 10 months of age. And how do we make the diagnosis, and how do we differentiate these 3 types of congenital esophageal stricture? So for this we require a CT thorax. CT will show the tracheobronchial remnant in the lower part of the a cartilaginous structure in the lower part of the esophagus, and final confirmation of diagnosis is by biopsy, by endoscopic guided biopsy.